Thank you all for being here. This is the Medicaid long-term care changes for New York State, and we're going to be talking about the care changes. So, okay. All right. So any of you who don't know me, my name is Nicole Christensen. I'm the Director of Care Answered, and we provide patient advocacy and care coordination so people can access their best care. And that comes in the form of many different ways and many different transitions. If people are diagnosed with a catastrophic or chronic illness, or their health is in decline, or people are just questioning what their options are, what care is available, we're there to help them access their best care in the transition from even going to a doctor's office or going to the hospital, coming out of the hospital, going into rehab, coming out of rehab, going into a nursing home or assisted living. In all those cases, we're there, again, to be the quarterback and coordinate all the care so that people know all of their options. And one of the ways we assist in that transition of care is really with community Medicaid, because that transition is real and it can be a bit daunting, and there's been many changes that have begun. So we're gonna get to it. I do wanna say a few housekeeping rules. If you have any questions, please put it in the chat, or you can raise your hand and I will answer them. After each segment, I'll be looking for the questions as well. And I will try to answer all of them. Please do know that these changes are coming with not a lot of clear timetables. So what we are seeing, did any of you hear anything I just said? Okay. Sorry about that. So when it actually happens is going to vary because they haven't decided yet. So without any further ado, let's get started because we have a lot to cover. Okay, so first question is, what is Medicaid, right? Medicaid is insurance for low-income people, health insurance. It can be used with one's doctor, but what we're going to be talking about is community Medicaid. Oftentimes when people hear Medicaid, they think of institutional Medicaid, and that is nursing home Medicaid. So that's to help pay for the costs of care in a nursing home. Then there is community Medicaid, which is what we're going to be talking about. And that is long-term home care. So when you need assistance with care in the home so that you can age in place safely and get the care that you need. Now, the first thing that a lot of people are talking about is the financial changes to community Medicaid. This is not my expertise. However, in my virtual Rolodex, I have lots of great friends who provide assistance with this, either Medicaid specialists or elder law attorneys or special needs attorneys. They can get to the nitty-gritty and help you out with this. So I really suggest that you or your clients or your loved ones really go and talk to those experts. And you can certainly call on Care Answered to navigate you to those experts so you can get the answers you need. But I think the biggest thing that we hear about and talk about is the look back period for community Medicaid. This didn't so much exist before. Before, October 1st, there wasn't really a look back period, meaning transfers that you made were not looked at and caused a penalty to those applying. Now, starting in theory, October 1st, the look back period can be as long as 30 months. So any transfers that one makes can be looked at and used as a penalty, meaning that can delay your receiving community Medicaid or being eligible for community Medicaid financially. Now, I got this slide that you're looking at, hopefully you guys can see, is directly from NYLAG, which stands for the New York Legal Assistance Group. They're a fabulous group and resource. If you haven't utilized them before, they're really quite wonderful, nonprofit. So any transfers of assets before October 1st of this year will not be subject to a penalty. Okay, so it was supposed to start October 1st, but they've delayed it to January 1st. So the look back is supposedly never going to be looked before October 1st, 2020. And then January 1st, 2020, the look back is 3 months to October 1, 2020, and so on and so forth. So it's not immediately going to be looking back 30 months as they set it up now. It doesn't get to 30-month look back until April 1st, 2023. So what does that mean? That means potentially it won't be looking back as far, so maybe the penalty won't be as much for those that are applying during this time period. If I like to look at the silver lining, so that might be good. The other thing I would say is, although this is not written in stone in any way, shape, or form, but the common belief or hope is that transfers that happen between the 1st and the 31st of December will not be looked at either. That is not real. That is the hope and the belief of most folks that I speak to in the elder law community as to what the policy actually says. So either way, the takeaway should be for all of us and for our clients and loved ones and community is look into, if community Medicaid is something that you may be interested in, looking into it, planning for it is something that we should be doing now. Okay, now we're going to get into the qualifying medically for community Medicaid. And that's where Care Answered really works that agenda. So to be eligible for community Medicaid, first step is still to be proven financially eligible. Then the next step is medically eligible. So here are the general steps as they work now. Generally, after you've been proven financially eligible, the general rule is that you need 120 or more days of assistance with your ADLs, commonly known as activities of daily living, to enroll into a managed long-term care plan. That's what MLTC is, managed long-term care. So the first thing that happens is that the state, through Maximus, an organization called Maximus, sends out a nurse, or in this COVID time, sends out a, does it virtually or telephonically, and determines if you are eligible medically. So they say, let's say they determine you are medically eligible for community Medicaid. Then the consumer selects a managed long-term care plan or several to come to evaluate them. The MLTC then tells you how many of care hours they will provide during a week. So they would be in charge of telling you how many hours of care in the home you will get through either CD Pass, which is consumer-directed personal assistance, or through a personal care, which is through a home care agency that is contracted with the managed long-term care plan. So this process is going to change as soon as January 1st. It can come later. because the directives and how they're going to do this is not clear yet. Now, what we're going to talk about now is ADLs. Sorry about that. ADLs, as I said, activities of daily living. So, as of January 1st, 2021, the activities of daily living will include ambulating, walking, personal hygiene, dressing, eating, bathing, transferring on and off the toilet and toilet use, and turning and positioning in bed. So those are the activities of daily living that count towards eligibility for community Medicaid. Starting January 1st, one must require physical maneuvering with at least 3 of these ADLs. And what does that mean? So mom has a walker. She utilizes the walker, and that helps her ambulate, but she can use it on her own. That means she doesn't have a need for physical maneuvering with that ADL. Another scenario is mom has a walker, but to get to it, she needs somebody to physically help her get up on her feet to use it. And potentially when she's using it, she's unsteady. So she needs somebody holding her back or holding her hand or helping her, physically maneuvering her body to assist. That would be physically maneuvering with the ambulation. The other new thing is that those with a diagnosis with dementia will only need 2 ADLs and only need a minimum of supervision. So what does supervision mean? And again, that only is appropriate, that supervision is only of the ADLs, only applies to those who have a dementia diagnosis. So supervision, let's say dad has a walker. He utilizes it to walk and he can walk with it. But then he needs somebody to assist him in utilizing the walker, meaning, okay, dad, put your hands on both sides, then help yourself up, okay? And then we're going to put one foot in front of the other. That's supervision and that's cueing. So supervision will be, if he doesn't get that cueing or information or somebody's not there, he is likely to fall. He needs supervision because he could fall backwards. So that's supervision. So they only need a minimum of supervision with at least 2 of those ADLs. If it's more, then they could qualify. And of course, if they need more than supervision, they need actual physical maneuvering, of course, that would be qualified as well. So what are the changes in this, in the ADLs? One of the things that they don't list specifically includes when people are incontinent, meaning they can't use a toilet, but they have no control of their urination or bowel movements. The other thing that it doesn't include is transfers other than toilet use. Like I mentioned, if transferring is basically from sitting to standing, standing to sitting. So if for some reason grandma can use the toilet because they have the grab bars there or what have you, but can't get up out of a chair, it's not specifically said that that kind of transferring is also deemed an ADL. The other thing not mentioned is medication administration, those that need actual assistance with the administration of medication. So if people needed that help, that is not specifically included in these new guidelines as an ADL. Then, in addition, they're not including, at least with these 3 or 2 minimum that I mentioned, IADLs, which is managing finances, handling transportation, shopping, preparing meals, using the telephone, laundry, medication management, housework, those kinds of things are not going to be included. In addition, currently, if people had a household need, meaning they couldn't clean or cook, they could be potentially eligible. That is going to change with this change of rules on January 1st, 2021. Okay, I am going to look at the chat because I can't see it here to see if you have any questions. So I'm going to stop the share for a moment. Okay. Oh, okay. So there was a question about IADL. So an IADL, that's a really good question because I keep forgetting acronyms. So IADL, let me get back to you on that. I can't remember what the I stands for, but I will remember it by the end of this. But I will, instrumental, thank you, Pam. Instrumental activities of daily living is what the I stands for. Thanks, Pam. Okay. Now, let's again talk about the change in the process for community Medicaid. The assessment by the state via Maximus is going to stay the same. Okay, so when I said before that right now that's the first assessment, that seemingly will stay the same. However, there seems to be another assessment by an independent doctor who potentially determines the hours. Well, the Department of Social Services will actually provide the number of hours, apparently, according to these new changes. But an independent doctor will also do an assessment. Now, an independent doctor means a doctor that is not their current primary care physician and likely is not a doctor known by the patient at all. So this causes a bit of concern because they don't know the patient and they don't know the patient's needs. And in addition, it's not clear as to what information they must garner, if any, from the patient's primary care physician. So that is definitely strange and new because it's somebody that has really no understanding of the person, of the patient, except for potentially on paper and what they have assessed through Maximus, making a determination about their eligibility for community Medicaid. So that's a big difference. In addition, after the hours are determined, if the number of hours are over 12 per day, it goes to an independent panel who will determine if it is safe for the person to remain in the community. So who are these folks? We don't know yet. How do they say that somebody is safe to live in the community or not? I don't know. I'm sure all of us know and appreciate and love people who are bound and determined to stay at home and age in place and would need over 12 hours of care to do that and are in no way, shape, or form wanting to go into a long-term care facility for whatever reason. What does that mean for them? Does that mean that they can not get the hours that they need and languish at home without any care because they're not eligible for community Medicaid because their needs are too great? We don't know those answers yet, but that's certainly of concern to the advocacy community. So I have, through Care Answered, have had the experience of providing or helping people get 24-hour live-in care or 2 12-hour shifts. That means 2 different aides providing 12 hours each per day, because that was the need for them to be able to get the care that they need. So the idea that that might be in jeopardy is definitely cause for concern. Another change is that assessments done by, I'm not sure who yet, will be done annually rather than every 6 months. Okay. So the changes in the Medicaid process, and I often get the question is, when do these actually take place? I don't think anybody actually knows when they are going to actually take place. Part of it is because of the pandemic, and a lot of it is because I don't think they know how they're going to actually do it, the logistics behind it. But these are some dates that are floating in the ether. Please do not hold me to them, because again, they're floating in the ether and they could be incorrect. But as of now, the state is creating an assessment system that takes the MLTCs pretty much out of the process of determining the hours of care. As I mentioned before, when I was talking about the new process, you didn't see MLTCs in there at all. So, so that could begin, April of 2021. So this April. And the primary care physician out of the process of prescribing a personal care service or CDPAP, again, consumer-directed personal assistance program, may be done by the independent doctor, who again may have no real understanding of the patient, and that could happen 2022, or potentially earlier or later. It's not particularly clear at this time. I will say that what I'm seeing is a real push for dual eligibility programs. And what that means is a combination of Medicaid and Medicare programs. That's different from saying I have community Medicaid and I have Medicare and I have a supplemental Medicare policy. This is actually all in one. And so those dual eligibility program include PACE, which is basically a medical model daycare where the services are all on site. So your primary care physician, a social worker, potentially other specialists, and different engagements, physical therapy, are all on site. So you leave your home to do that, but then you come back home, obviously, to sleep. You still live at home. And that's managed by the insurance provider. In Care Answered's experience, a lot of our clients are not interested in that because they don't want to be going to a site every day. And I presume until this pandemic's over, nobody's going to be as interested in that kind of program. The other one that there seems to be a push to is the Medicare Advantage Plus program, which is they have a Medicare Advantage plan with home care, using only providers that take that insurance carrier. So when we think of an MLTC as an insurance, it would fall under that particular insurance carrier. Again, none of these plans are bad at all. It's just a matter of if they fit the need of our clients, as far as Care Answers is concerned, meaning that their current doctors that they like and they trust and they have a history with, are they on a provider for that insurance? So that's a question. And then the limited, sorry. Going the wrong way, sorry. So, and their MLTCs are going to be somewhat limited, right? Limiting MLTC's scope. So the managed long-term care plans are going to be, their reach is going to be prevented, I guess. As far as enrollment, they're putting caps on it. So I feel like they are pushing the dual eligibility program. So potentially we'll see more in that. CDPAP, as I said, that's Consumer Directed Personal Assistance Program. There's going to be some changes about that. So that means that you have a loved one, a family member, a friend, a neighbor, somebody that you knew that provided great care to somebody else you knew. They could be paid to provide the care through MLTC, and that would be through the CDPAP program. That program will still exist. However, starting January 1st, 2021, those that are eligible will not be specifically informed about that program. So please know that it exists, but there's nobody going to be telling people. So we, as loved ones, as providers, as people that assist those that are in this program, we can let them know, and they still have access to it, but they won't be told specifically about it. The other change, it's not really a change, I've been talking about it for quite some time, is what they call the MLTC lockdown. So they've had this as a potential policy, but have not actually gone through with it through CMS and they won't be doing it until December 1st. So that means that those who have a managed long-term care plan, they can transfer to another managed long-term care plan freely within the first 3 months or 90 days. Then after that, the rest of the 9 months, they have to stay within the managed long-term care plan that they have selected. So after 3 months, you're in it for the rest of the year. They can only transfer for good cause during the last 9 months. In the first 3 months, just like it is currently, you can change for a number of reasons, any reason really, but that's going to change, and you'll be locked into the same plan for the whole year after the 3 months. They can, however, transfer to or from the PACE or the MAP program. Those are the dual eligibility programs I mentioned. So that's a lot, I am sure. So I'm going to check again for any questions. See anything in the chat? Okay, so one of the questions was, what would be the advantages or disadvantages of the change of assessments to annually from every 6 months from an advocacy perspective? Hopefully it won't be a huge change because hopefully when there's a health decline or hospitalization, they'll still come to assess. That's been the case historically. So if somebody is hospitalized, or if a family member or loved one or somebody says, or the member themselves says, my health has declined, I need some more help, they could be assessed again. But I find in general, more assistance is better than less, and making sure that somebody is being looked at and evaluated for their care needs and not kind of left up to their own devices and just assume no news is good news is not necessarily ideal, because a lot of people won't say that they need more assistance or they would like another evaluation. So that 6 months automatically, I think, is generally helpful. So that's my thought. I also don't know who's doing it, this annual assessment. So that's still unclear to me. I hope that answers that. What the steps are to take. As I said before, apply for Medicaid sooner rather than later to avoid these changes potentially negatively affecting you, your loved ones, your clients, your patients. Because again, I'm hoping that both for the look back period as well as the care will be kind of in limbo for at least those months starting ending December 31st. And again, speak to your elder law attorney or your special needs attorney now to plan appropriately. That's for any of us who are adults. Just get on there, get a plan so that nothing hits you or blindsides you or your clients or patients or loved ones or yourself if the need comes to pass. And always, obviously I'm a patient advocate, but just in general, get an advocate now to best assess what the care is that you may need. So again, you can be prepared. And I will continue to do updates because this is an ever-changing situation. So I'll be here, Care Answered will be here providing updates so you can know as soon as we know. I blog about it as well as do webinars. So come to us and we will assist in any way possible with the information. And then I guess lastly is, this is our contact information, and to let you know in this long-term care, what to do, how to navigate it, we're going to have a webinar on Thursday, October 29th at 2:00 regarding long-term care insurance. It's how do you get it? I have so many clients within Care Answered that don't know how their policies work. Don't know when to submit a policy, don't know if they should submit a policy, don't know how to submit a policy to get the care that they actually need. And it's so important to do it right so you can get those benefits that you paid for. But also, we'll have Mark Abadami here to tell us about getting the long-term benefit for yourself or your client or your loved one. When it's appropriate for you, just basic information about long-term care insurance now. So we'll kind of go soup to nuts about getting it and about how to really utilize it and get the benefits you deserve. So that's coming up on Thursday, the 29th. So with that, we did well. Does anybody have any more questions? I'm looking in the chat. And I'm going to take everybody off mute so that you can speak. As long as I figure out how to do that.
I unmuted myself.
Great.
Okay, I have a question. I started to type a question, but it's not going through. So can I ask a question? Okay. So over the summer, I had a client in skilled nursing. She was there for 7 months. I got her nursing home Medicaid and started discharge planning. Referred her to MLTC for home care. The MLTC would not start services until she was discharged and the nursing home tag was taking care of the Medicaid number. And the nursing home would not take the tag off, would not put in for conversion until she was through the door. So you can only imagine how stressful that time was for both the client and myself. Absolutely. I had to arrange for private care to tie her over, a little bit of cha until all this was done. It is crazy.
Yeah.
I couldn't get any help with this at all from anywhere. I reached out to NYLAC and I didn't hear back from them. So I never heard anything like this. And how do we manage this? Because I'm sure it's going to happen. It's going to get worse.
Yes, that's a good question. So I haven't had that exact experience generally, but I will say that MLTCs now are not participating in nursing home care. So once you've been, if the other way around, right? So if you had community Medicaid and then went into a nursing home, it's kind of severed ties at this point with the MLTC, especially after 3 months, they're
Right,
no longer.
right.
Um, Getting the opposite, generally with our clients at Care Answered, we get the Maximus done potentially while they're in. I know that they were on Medicaid, but we still start the other process. So we have the Maximus evaluation while they're in the facility, and then the MLTC cannot assess unless they can go into their home. So that's been a common thing. But before anyway, they could go into assess the person in the skilled care facility and go separately with somebody that would let them in, of course, to the home.
But
So they can assess on both parts. It may have been because of the pandemic. It
no,
may have
no, it
been
wasn't.
because they didn't want to, but that's been my experience in the past. I haven't had that, oh, we have no care.
This particular MLTC did not ask to go into the home for an assessment. What they said was that they're not going to get paid if they pick up the client before the nursing home tag is taken off. And the
Right.
nursing homes is
This
saying,
is a coding issue. Yeah.
right, and the nursing home is saying, what happens if we take it off and she stays? You know? And I mean, I'm sure this is not the first time this has happened. People must have heard about this before. I mean, back in the day when I worked in nursing home, this never happened. So
Mm.
I don't know.
Yeah, I don't know. I've not had the experience of that being a barrier, but I'm sure it may have. I shouldn't say I'm sure. I have no idea, but it may have something to do with the lack of kind of real collaboration, I want to say, or contractual obligation through MLTCs and nursing homes at this point, which is fairly new. I'm sorry that you had to go through that.
It's a horror. Thank you.
You're welcome. Does anybody else have any questions? You can take yourself off mute. Oh, okay. So I see a question here. I'm sorry. Can you briefly review the process for joining the dual eligibility program and briefly remind again how that might work for people, especially MAP? So the review process will be the same, as I just mentioned, starting January 1st, 2021. And the review process for MLTC and these other programs were also the same now. So the review process doesn't change as far as I can see from all of the changes that are being made. The only, it would be just selecting a different long-term care plan, if you will. So again, the dual eligibility programs, it doesn't really change. And as far as I know, but anybody can chime in here, I don't think we have any PACE programs on Long Island anymore. Can anybody say differently? I don't think we have them anymore. So maybe we'll see a comeback of those. I don't know. But in New York City, we do. Any other questions?
So in terms of um, people who need at least 12 hours or more,
Yeah.
they are now going to have an independent review, you say, to
Mm-hmm.
see if I mean, they have been talking about this for a while. This is not actually new. But so what do you think is going to happen? They're going to suggest that people go to nursing homes if they don't think they're appropriate to remain in the community?
That's what I'm saying. I'm saying that I don't know what their plan is. I don't even know who's on this review panel to make that decision. Um, it's it. I don't know. I don't know. You can't force somebody to go into a nursing home. We all have free will and we have rights. So my question, as I posed before, is if you have somebody that says, I am not going into a nursing home, and then they are refused community Medicaid because they need more than 12 hours, what happens? Do they not get community Medicaid? Do they get less than 12 hours even though they need more? I don't know what the answer to that is, but I find that very disconcerting as somebody that advocates for people oftentimes that have high needs and they are able to age in place and get quality care by getting a 24-hour shift or a split shift. So the fact that that may be less likely to get for people that are most in need of it, it's strange. And especially during this pandemic where people are not as comfortable, not that some people would never be comfortable at all, but it might be less comfortable during this pandemic to go into a nursing home and then say, oh, you have to go. They can't do that. And it goes against the American for Disabilities Act to say that somebody cannot live on their own.
Yeah.
So
that's going to be challenged. But
yeah.
let me say something, and then I'll shut up. This same person, I mean, I had the summer from hell, literally with this case, okay? I think it's very important for us to, when Maximus or even the MLTC is evaluating the person for services to determine the hours they're going to get, that we be on the virtual interview with the client. We know that the elderly, they never think that they need help, or even if they know they do, they minimize it. So the information you just shared, that if the person doesn't need help getting to the walker, and if that's not made clear that you have to bring the person up and put them on the walker, if that's not made clear, then they're not going to get really any kind of service. And we know for a fact that a lot of people need that. But you ask an elderly person, do you walk with a walker? Yes, I walk with a walker. And they don't explain how they get there.
Absolutely.
And
Everybody should have an advocate because even the loved ones can speak in a way that they might not be using the vernacular properly in this case to make sure that their loved one gets the care that they actually need. But in addition to that, just not to scare people, there's not actually explicit language that that says that you have to have a person there or that you can have a family member there. So that's a bit of concern with this new policy as well. Let me see, I think, does anybody else have any questions? You can unmute yourself if you're trying to ask questions and I don't see you.
Nicole, this is Steve.
Hi, Steve.
Hi, I had a quick question. It doesn't relate specifically to the changes, but it's an overall question. If somebody does get approved for a community Medicaid for a certain number of hours that includes a live-in or 2 12-hour shifts, if the person's house doesn't have an extra room for that aide to sleep in, is it acceptable to set up a cot or something in another room for that person to sleep in, or how does that typically work?
Yeah, I can tell you from my experience that has worked in the past. Okay. For lots of folks that don't have that space, but obviously an aide it has a right to his or her privacy as well. So there's things that we've done in the past to make sure that there's some privacy with also being able to have that. But the other thing about split shift is it's 2 different people. So performing 12 hours. So that's for folks that actually they can't have somebody sleeping. They need care all the time. So a 12 hour for a split shift, you don't need an extra bedroom because nobody's sleeping and they're working the whole time.
I see. Okay. Thanks.
Absolutely. All right, everybody. So I want to thank you again for all being here. It's been my pleasure to have this information for you and to answer your questions. And just be safe out there. And again, if the biggest takeaway is if community Medicaid is at all of interest or appropriate for you, your patients, your loved ones, your clients, try to get on the stick now and contact me if you need assistance with finding, locating a Medicaid specialist, a elder law attorney, special needs, because I know the best. And I'll be more than happy to give you that information so that you can access the care.